Down syndrome is the most common chromosomal anomaly in humans, and this syndrome was named after John Langdon Down, a British physician who first described its physical features in 1866. Down syndrome causes varying degrees of intellectual and physical disability and related medical problems. Children with Down syndrome are at higher risk of having cardiac defects, thyroid disorders, vision and hearing problems, gastrointestinal tract abnormalities, muscle and joint related problems, seizures, obesity, and leukemia. The majority of children with Down syndrome have an extra copy of chromosome 21. However, the genetic diagnosis is confirmed by doing a karyotype. Children with Down syndrome often appear in the development station of clinical pediatric exams. Let us see how a child with Down syndrome is examined to understand the physical features of this genetic condition.
ආචම්ම මම ડોක්ටර් කෙනෙක් මම ඔයාගේ බබාව චුට්ටක් බලන්න කියලා හදන්නේ කම නැද්ද? පුතා ඔයාව චුට්ටක් බලන්න. In examining a child with Down syndrome or trisomy 21, it is first important to note the growth parameters of the child. Children with Down syndrome are generally small and their stature is generally shorter than that of an age-appropriate healthy child. And also head size is small. Therefore, it is important that you measure the occipitofrontal circumference and check the weight and height parameters and plot these parameters in a Down syndrome specific growth chart. Look at this child's face, and this child has flat facial features including a flat nose and a flat and small nasal bridge. And if you look at the eyes of the child, she has upward slanting eyes and there is hypertelorism, and the ears are abnormal and low set, and they keep their tongue generally outside, kind of protruding the tongue because they have a small mouth. Note bilateral epicanthic folds. Epicanthic fold is a skin fold of the upper eyelid that demarcates the inner corner of the eye. And examine with the torch in the cornea for evidence of brush field spots and for evidence of any cataract. Look inside the mouth, look for any evidence of an arch palate and evidence of fissured tongue. They generally have protruding tongue because the mouth oral cavity, the size of the oral cavity is small so that the tongue protrudes out. Look at the neck. The children with Down syndrome, they generally have a short neck, and there can be webbing of neck which is absent in this child, and also there are redundant skin folds in the region of the neck, giving rise to webbing of the neck. Look at the head shape of this child. The head is flattened posteriorly, and this head shape is called brachycephaly. Next, we will look at the hands. Now, a child with Down syndrome has an abnormal skin crease which is known as the simian crease. And you can see the simian crease in this child. And also they have abnormal dermatoglyphic patterns of the palmar skin. And if you look at the fifth finger, there is shorter middle phalanx, and that leads to an incurving of the little finger, which is known as clinodactyly. And generally, they have short hands. Next, we will examine the legs, especially the feet of this child. Children with Down syndrome can have a flat feet, but it is absent in this child. And the other striking feature is the increased gap between the first and the second toes, and that is known as wide saddle gap, which is present in this child. Look how this child places her two lower limbs. You can appreciate the child's legs are hypotonic. Characteristically, children with Down syndrome have central hypotonia, which means they are hypotonic but their reflexes are normal. Look for any chest deformities, and it is very important that you auscultate for heart sounds and the presence of any cardiac murmurs. Children with Down syndrome can have heart defects including common AV canal defect, ventricular septal defect, atrial septal defect, and tetralogy of Fallot. So it is very important that you auscultate the four cardiac areas for the presence or absence of any murmurs. And also, children with Down syndrome can have a surgical scar in the right hypochondrium and the epigastric region, and that is suggestive of previously repaired duodenal atresia. However, you can appreciate that there is no surgical scar in this child, suggestive of absence of any duodenal atresia. Note the presence of small umbilical hernia in this child, which is again a feature of trisomy 21.
I examined this cheerful child who looks adequately grown, and I would like to plot her growth parameters in a Down syndrome specific growth chart. She has multiple facial dysmorphic features including upward slanting eyes, epicanthic folds, flat nasal bridge, small low-set ears, a protruding tongue, and micrognathia. She has brachycephaly, a flat and broad face, and a short neck. Examination of her eyes did not reveal any evidence of brush field spots, nystagmus, squints, or cataracts. Examining her hands, I noticed small fingers, clinodactyly, the simian crease, and small wide hands. There was an exaggerated gap between great and second toes in both her feet. She has generalized central hypotonia. She does not have chest or spine deformities. Her cardiovascular system is clinically normal and no scars were seen on the abdomen. I would like to proceed with developmental examination. With regards to her management, I would like to review her thyroid functions, echocardiography, and hearing and vision assessments. She needs care by a multidisciplinary team to address complex issues including developmental delay, cognitive impairment, and multiple other medical problems. Reviewing her karyotype studies is important in offering genetic counseling to the parents.